Hello guys, welcome back to my channel. This video is about the anatomy of the shoulder joint. It's something that I keep forgetting. It's the most volatile thing. I cannot remember joints, so that's why I've decided to make this video. So let's get into it, starting with the basic points that we already know. It's a ball and socket type of synovial joint. Articulation of the glenoid cavity with the humerus, more specifically glenoid cavity of the scapula to the head of the humerus. The pectoral girdle is articulating with the arm basically. Now the blood supply. So how do you remember the blood supply? If you remember the axillary arteries giving their anterior and posterior circumflex humeral arteries here, and also when we talked about the scapular anastomosis, we saw the suprascapular and the subscapular coming from the back basically. I mean, if this is the scapula, you have the suprascapular coming from here and the subscapular coming from here. So these are all related to the scapular region and the arm region, right? So we have to take in account the arm region and the pectoral region to say for the blood supply and nerve supply. So blood supply is anterior and posterior circumflex humeral vessels and suprascapular and subscapular arteries. Now nerve supply will be also similar. So relating to the posterior circumflex humeral, we'll have axillary nerve. You'll see the axillary nerve is always with the posterior circumflex humeral vessels. And then arm, when we talk about arm, we can't leave out musculocutaneous nerve. And then scapular region can suprascapular nerve. So that is the nerve supply. One for the arm, one for the axilla, one for the scapular region is how I remember. Now coming to the structure. So because the glenoid cavity is too shallow, it's actually the head of humerus is 4 times the glenoid cavity. Structurally, it is a very weak joint. But this arrangement of the humerus and glenoid cavity permits mobility in the shoulder joint. As we know, it's one of the most mobile joints of the body. So structurally, because of that, it's very weak. So there are other things which reinforce stability in the joint. First thing is atmospheric pressure. Simple, forget about that. Next is muscles. So the muscles which are attaching the humerus to pectoral girdle, biceps and triceps. So why not pectoralis major? Because even that has its insertion on humerus and it's originating from somewhere from your pectoral region, because these muscles are there in the arm. Their only attachments are there in the pectoral region, so they're attaching the arm to the pectoral region. But pectoralis major's bulk of the muscle is there in the pectoral region, so it's not doing a great job in attaching the arm to the pectoral girdle. That's why we're not mentioning pectoralis major here, only biceps and triceps. Next we have the coracoacromial arch. So we have the glenoid cavity where the head of the humerus fits, and then at the top we have this coracoacromial arch. So it acts as a secondary socket for the humerus to fit. So it can loosen up there is what I'm trying to say. It can ease or it can sit there more comfortably because of the presence of the arch. So coracoacromial arch acts as a secondary socket. This is the coracoacromial arch. We'll definitely talk about it more in the video. Last point is glenoidal labrum, labrum glenoideum, which is the fibrocartilaginous rim surrounding the glenoidal cavity, which deepens the fossa, which fixes a little bit of this problem that we discussed here, right? Even in the ligaments, we'll see glenoidal labrum, fibrocartilaginous rim, which covers the margins of the glenoid cavity. The other ligaments are, so ligaments is like one of the most important things to study when we're talking about a joint. So we start with capsular ligament. So capsular ligament is very loose. We can see even in this picture how it is hanging like this. It's a loose, and it's a loose ligament around the capsule. It permits movements. So it is the least supported inferiorly. That's why joints, whenever there's shoulder dislocation, there is an inferior dislocation, and because axillary nerve is somewhere here like this, it's passing through here, so inferior dislocation will cause damage to the axillary nerve, and that is one of the applied anatomy points. So that was about inferiorly. Now we talk about medially. Medially, it is attached to the scapula beyond the supraglenoid tubercle and the margin of the labrum. So I do not think I can show you that in this, and I think it's not that important either. So I'm gonna move on. Laterally, it is attached to the anatomical neck of the humerus, right, which we can see here. This is the anatomical neck. But what is happening here is a deviation. So there is an exception that inferiorly the attachment extends down to the surgical neck of the humerus. Okay, and then you can see superiorly, you see this is coming laterally going here, but it's deficient over here. So superiorly it is deficient for the passage of what? The tendon of the long head of biceps brachii. Alright, so that is about the lateral attachment of the capsule. Anteriorly, we'll see supplemental bands, okay, which we can see in this diagram. So anteriorly, the capsule is reinforced by supplemental bands, the superior glenohumeral ligament, middle glenohumeral ligament, and the inferior glenohumeral, superior, middle, inferior glenohumeral ligaments, which are supplemental bands that reinforce the capsule from anterior and from the anterior perspective. So that was about the capsule. Now, the area between the superior and the middle glenohumeral ligament is a point of weakness in the capsule, which is common site of anterior dislocation of the humeral head, and it is actually called as foramen of, however you want to pronounce this, Wiedbrecht. I do not know. So you see, the area between the superior and middle is a point of weakness in the capsule, where the anterior dislocations take place. The capsule throughout is lined with the synovial membrane, and that's why this joint, this tendon, which is coming from the deficient area, is also lined with synovial membrane. An extension of the synovial membrane forms the tubular sheet for the tendon of the long head of the biceps brachii. So that's about the capsule. So we have to talk about medially attachment to the scapula, laterally to the anatomical neck, and the two exceptions that we talked about here, and then we talk about anteriorly the three supplemental bands and the foramen of Wiedbrecht, and we talk about the anterior dislocation that could happen. Next is the coracohumeral ligament, from the root of the coracoid process to the neck of the humerus opposite the greater tubercle. So just coracoid process to the root of neck of humerus is also enough to remember. I think we do not have a diagram for this. Maybe in the further, yeah, we don't actually have it, so I'm sorry. Next is the transverse humeral ligament. If this is the bicipital groove, it is basically bridging the upper part of the bicipital groove. So the tendon of the long head of biceps brachii is passing deep to the ligament. So first it's passing here, and then it's passing here. Here it's making a deficiency in the capsular ligament. Here it is passing deep to the transverse humeral ligament. So those are, and we already discussed about the gunal labrum. So those are all the ligaments of the shoulder joint. Now talking about this. Okay, so this diagram is pertaining to the relations of the shoulder joint, which is also an important part when we're talking about anything in anatomy. So we're just going to name every part. So this is a posterior, these all are the posterior relations. And then we have the anterior relations this side, and we're going to go into the details of them. We have the capsule, we have the glenoidal labrum here, and then we have the intracapsular part of the tendon of the long head of biceps, which goes out, and it has the tendon sheet surrounding it. So that is the tendon of the long head of biceps, which is intracapsular ligament. Done. Now posteriorly we have the sit muscles, and that is supraspinatus, infraspinatus, and teres minor. Whereas anteriorly we have the subscapular muscle, because the anterior surface of the scapula is connected to has the subscapularis muscle. The posterior surface is divided into supraspinatus and infraspinatus. So that has fossae, supraspinatus and infraspinatus fossae. So that has these muscles, and the teres minor. So these are the posterior relations, these are the anterior relations. Then as the coracoid process is here, and as we know from the coracoid process, there's the attachment of two muscles, origin of two muscles, which is coracobrachialis and the tendon of the short head of biceps, I think, if I'm not wrong. So both of them arise together, as we can also see in the, I think clearly in the dissection also. So this is the coracobrachialis and the biceps. What are the two big muscles here? Nothing but it's the same muscle, which is the deltoid, but these are the posterior fibers, these are the anterior fibers of the deltoid. Inferiorly, here we have the triceps brachii muscle called long head. So important to remember long head. We have the axillary nerve, as we already discussed, and I told you that the axillary nerve, it accompanies the posterior circumflex humeral vessel. So here we have the posterior circumflex humeral artery. So clearly we have the subacromial bursa and the coracoacromial arch. The coracoacromial arch is made of the coracoid process, the coracoacromial ligament, and the acromion process, together forming the arch. So these are all the relations of the shoulder joint. So one diagram will cover it all. So this, we already talked about the subacromial bursa. The subacromial bursa is also called as the subdeltoid bursa. Apart from that, we have the subscapularis bursa, which communicates with the joint cavity, and we have the infraspinatus bursa. That means one anteriorly, which is subscapularis bursa, one posteriorly, which is the infraspinatus bursa, and the subacromial, which is this, it actually is continuous with the subdeltoid. It may be separate, but then sometimes continuous also. So the line which is given here in BDC is that collectively both subacromial and subdeltoid are called subacromial, which separates the acromion process and the coracoacromial ligaments from the supraspinatus tendon, and permits a smooth function. This is the supraspinatus. Oops. This is the supraspinatus. And these are the coracoacromial ligament, coracoid process, acromion process. So this is separating these both. This permits smooth motion. So if there's a failure of this mechanism, then inflammatory conditions of the supraspinatus tendon are seen. Alright? Now the last thing is the movement. So I'm going to start with abduction, which is something I think if the teachers will see and they'll be like, oh, this person knows the topic. So 0 to 90 degrees of abduction is done by deltoid and along with its supraspinatus. Then 90 to 180 degrees is serratus anterior. And I'm sorry, I messed it up here, I think. 90 to 180 is serratus anterior. But after that, it cannot be 90 to 180 again, right? Okay, so the point is both serratus anterior, upper and lower fibers of trapezius all contribute towards 90 to 180 degree abduction of the shoulder joint. And remember, it's a shoulder joint, it's not arm. The arm you can probably move after 180 degrees also, but the shoulder won't move much. And then that is abduction, right? The adduction is caused by biceps pectoralis major and latissimus dorsi. Both heads of the biceps, pectoralis major, because biceps is connecting the arm to the pectoral region. Pectoralis major is also connecting the pectoral region to the arm. So that's why when they're contacting, there is adduction taking place. Posteriorly, this posterior reinforcement of this movement is being done by latissimus dorsi, which is also doing the similar thing that is connecting the back to the arm. That is adduction. So similarly, the pectoralis major ka clavicular head helps in flexion. Now what is flexion? That is of the shoulder joint is the arm moves forward and medially. That we call it the flexion of the shoulder joint. So that's why clavicular head of pectoralis major and the anterior fibers of deltoid. The posterior fibers of deltoid, latissimus dorsi and teres major helping in the extension. That is the arm moves backward and laterally. Okay, so in adduction, we had pectoralis major and latissimus dorsi. This is helping in flexion, this is helping in extension, along with teres major. And then in flexion and extension, we have the deltoid. Here anterior fibers, here posterior fibers. So flexion, extension, abduction, adduction, over. Now lateral rotation and medial rotation. So medial rotation is across the chest, in front or in the behind. Okay, but lateral rotation is away from the chest. This here again we get the deltoid fibers. So lateral rotation is obviously the posterior fibers of the deltoid away from the, if the posterior fibers contract, the arm will move away. If they are relaxing, or the opposite movement is towards your chest. So anterior fibers are contracting, medial rotation, posterior fibers are contracting, lateral rotation. And lateral rotation is also caused by infraspinatus and teres major. Medial rotation is done by the lady and the two majors. That means that is latissimus dorsi, teres major and pectoralis major. I think you should just remember that because I have no way of explaining that currently. So that's all for this video. Thank you so much for watching. If you want, you can revise all these labelings using this diagram here, and that will basically help you remember all the relations. That's all for this video. Thanks for watching.